So thanks everyone for joining us today for another session of the Philosophy and Psychiatry seminar. And it is my pleasure to introduce our next lecturer, that is Dr. Jacob Stegenga, and he's a professor of philosophy of science at the Department of History and Philosophy of Science at the University of Cambridge. So a little bit about him, his biography. He has taught before this in United States and Canada, and has received his PhD from the University of California, San Diego. He has been a senior fellow at the Leibniz University in Hanover last year, and now he's a professor at Cambridge. He has published on fundamental topics on reasoning and rationality and philosophical problems in medicine and biology. He is the author of 2 books, Medical Nihilism and Care and Cure, an introduction to philosophy of medicine. And he's currently writing a book, tentatively titled Heart of Science. So today he will be talking about a very interesting and inquisitive topic. The title of his presentation is "The Drug Worked for Me, but Did It?" So please, Jacob, the floor is yours.
Thanks very much. I'm really glad to be sharing this work with you. So thanks for the invitation. I should say that this is joint work with a former PhD student of mine, Hamed Tabarebe-Gomi. And towards the very end of the talk, I'm going to be presenting some very new results, and that's in collaboration with a PhD student in Munich, Lilian von Bressendorf. Okay, so the sort of situation that we're interested in is the following. Imagine there's a patient. She has some symptoms. She goes to the clinic. Her doctor diagnoses her with a particular disease and prescribes an appropriate drug for that disease. The patient goes away for, say a few weeks, and there's a change to her symptom profile during those weeks. She comes back to the clinic, and either she, the patient, or her physician infer that the drug was causally responsible for that change of symptoms. So we want to know, is that kind of inference reliable? And of course, I think we take this to be a very common pattern of inference, both on the part of patients and on the part of physicians. The drug worked for me. We want to know, yeah, but did it? How reliable are those inferences? So that's basically what I just said. And the punchline of the talk is what we're going to argue is that in some clinical scenarios, that kind of inference is indeed reliable. And in other clinical scenarios, and we think that these clinical scenarios are particularly relevant to psychiatry, those sorts of inferences are not at all reliable. Okay, so the talk is as follows. I'll just give a bit of background to the sort of debate that we're entering in. And then part 2 of the talk, I'll describe how we approach this debate. We use a model, a virtual model, in which we generate some simulated results. So I'll present the model, I'll describe the model, and then I'll proceed in part 3 to talk about the results of that simulation work. And then part 4 is an interpretation of those results. And then I'll just briefly speak about what we take the next steps of this research to be. Okay, so this is the question we're asking. Is clinical experience a reliable guide to inferences about drug effects, both from the perspective of patients and from the perspective of their treating physicians? So there's a bunch of philosophers and physicians who have been defending this form of clinical experience, including Mark Tonelli, who's a physician, Nancy Cartwright, a philosopher, David Healy, a psychiatrist. So Healy was responding to one of something that I'd written. Healy was arguing that no, psychiatrists can indeed reliably infer the effects of drugs. As many of you will know, the so-called evidence-based medicine movement, EBM, they emphatically say no to this question. And the response from Hamed and I, based on our results, is to argue that both sides are a bit too extreme, and we want to kind of cut between these 2 extreme views and argue that there are some conditions under which this sort of inference is reliable, but many other conditions under which it's not. So here's the evidence-based medicine view, which many of you will be familiar with. So evidence-based medicine gives this rank ordering of different kinds of methods based on the presumed degree of reliability of those methods. So near the top of this so-called evidence hierarchy are randomized control trials or meta-analyses or systematic reviews of those trials. Somewhere in the middle are non-randomized studies. And towards the bottom might be like case series, case reports, expert opinion, the kinds of things that you get from clinical experience. So evidence-based medicine is really committed to the view that this kind of first-person clinical inference is unreliable. Now, this debate comes out of, sometimes this debate comes out of skeptical views about medicine that are trial-centered. So I published this book a few years ago. It's kind of like the 5th birthday of this book, roughly. And this book was giving a very skeptical view about many domains of medicine, particularly medicine, which is focused on pharmaceuticals. But most of the arguments that I was giving were based on trials. So big randomized trials that show tiny effects or widespread biases of trials in clinical research, the funding effect of trials, getting evidence that supports pharmaceutical industry. So this was very trial-centered. And what some commentators on this book said is, yeah, it's one thing for the trials to show blah, blah, blah. It's one thing for the trials to be biased, but clinical experience shows something else. So I would get that response either from patients themselves or from some physicians. So I started to get interested in this kind of argument. This was an essay that I wrote in Eon magazine. It's available online, which made that kind of skeptical argument specifically about antidepressants. So I gave a very skeptical view about antidepressants in this essay. It was a public-facing essay, so many non-philosophers read it. And what was interesting is that in the comments section, many patients and physicians responded very thoughtfully by appealing to this form of inference, this first-person clinical experience. So they said, yeah, Jacob, you're painting this very skeptical view about antidepressants, but this friend of mine was taking these drugs and it really helped her. Or, yeah, I've been using this class of drugs for a long time. I've seen its benefits in the clinic. So I started to ask, like, how reliable is this kind of argument? The drug worked for me, or the drug worked for a friend of mine, or the drug worked for a patient of mine. Now, you might just think this is just an empirical question. It's just a question about the reliability of a mode of inference. So we can test it empirically. But I think that there's fundamental limitations to that because essentially the trials are showing one thing and clinical experience is showing another thing. And in order to test this empirically, we would have to have some sort of gold standard benchmark. But precisely what's at question in this debate is precisely what's motivating this research is the fact that trials show one thing, clinical experience is saying something else. So we think that we can't just directly test this empirically, although there are a bunch of empirical questions that are relevant to the problem. So instead, what we do is we try to model this form of inference virtually. So here's what we have in mind. We start with the following sort of background setup. We assume that once the physician has prescribed a drug to the patient goes away, and there's a change in symptoms over time. There's 3 families of causes of those changes in symptoms. One is the possible real effects of the drug. The second is the well-known placebo effect. And the third is just the natural course of disease. Like you've got a common cold, it's going to resolve itself within a week. So we take these 3 families of causes to be operative in changes in symptoms over time. And so we build those into our model in the following way. So we imagine the patient comes to the physician and the physician has to choose a drug. Suppose for a particular disease, there's 10 possible drugs that the physician can choose from. That's a pretty usual number for many classes of diseases. Like for depression, for example, there's roughly 10 possible SRIs or related drugs that the psychiatrist can choose. So the physician chooses from one of this class of drugs, and then those 3 causes operate, and then the patient either improves or doesn't improve. If the patient improves in our model, the physician's confidence in that drug increases, and that increases the probability that the physician will choose that particular drug for the next patient. On the other hand, if the patient doesn't improve, then that lowers the confidence in the drug, and that lowers the probability that that physician will choose that drug in the future. And so what we do is we turn up and turn down the strength of those three causes in this, so what we're calling this causal black box. So we can just turn up or turn down the strength of those three causes according to different kinds of diseases or different kinds of clinical scenarios that we think are pretty common. So what we do is we choose a common disease like depression or the common cold, and we get as much empirical evidence as we can about the strength of those three causes from randomized trials or meta-analyses. We build those strengths into our model, and then we run simulations, and we have something like 1,000 patients visit this physician, and the physician just iterates over time, and the physician learns or infers about the effectiveness of the various drugs that they can choose from based on what actually happens to these virtual patients. So that's the model setup. Now I'm going to describe to you the various scenarios that we're modeling. So we've got 6 scenarios. Each scenario is one of these columns in this table. The 3 strengths of causes, the main ones that I want you to pay attention to here, are real effectiveness, placebo effect, and natural course increment, like how much the patient can get better just by the natural course of improvement. So the numbers here range from 0 to 1, and that's just a measure of the strength of the cause of each of those 3 causes: effectiveness, placebo, natural course. The first 2 columns, benchmark 1 and benchmark 2, these are like sanity checks for us. So these are scenarios in which there's no placebo effect and no natural course. In benchmark 1, we have 10 drugs, and we vary the effectiveness of those drugs from 0 to 0.9. In benchmark 2, we have 10 drugs, and they're all equally effective, roughly in the like medium strength of effective, with, again, no placebo, no natural course. Column 3 is antidepressants according to what we call the champions. So champions of antidepressants, what they do is they go to the published record, they go to the very best meta-analyses of antidepressants, and they just read off the numbers from those meta-analyses and infer those numbers are directly indicative of how effective antidepressants are. So it turns out that, the very best meta-analyses of antidepressants in the drug group, roughly 60% of patients improve over the course of a trial. And in the placebo group, roughly 40% of patients improve over the course of a trial. And those trials last, say, 4 weeks or 6 weeks. So that's where those numbers come from, 0.6, 0.4. Natural course increment, there's not very much very good empirical evidence about the natural course of improvement for depression untreated, but there's some work. And this work shows that, like, for example, one study showed that over the course of 1 year, about 50% of untreated patients would get better. And so our time increment for this scenario, the use of antidepressants, our time increment is 6 weeks. So if you take 6 weeks, roughly divide that by 1 year, you roughly get a natural course increment of 5%. So 5% of patients would get better without treatment over 6 weeks. Okay, that's antidepressants according to the champions view. The next column is antidepressants according to the skeptics view. So the skeptics are epidemiologists like Peter Gotcha. So they're well known for doubting many classes of drugs. And what they say about antidepressants is as follows. They say, yeah, sure, really good trials of antidepressants demonstrate a small but non-zero effect size for antidepressants compared to placebo. But sometimes these trials include asking subjects to guess which group they're in. Are they in the placebo group or in the drug group? And it turns out that for experiments on antidepressants, subjects are pretty good at guessing which group they're in based on the presence or absence of side effects. So Peter Gotcha says that small but non-zero effect size is due to subjects accurately guessing what group they're in, and that exacerbates the placebo effect for subjects in the drug group. So that's antidepressants according to the skeptics. They say, look, these drugs aren't effective at all, but depression is very placebo responsive. That's non-controversial. So that's where those numbers come from, 0 and 0.4. And then same with the natural course increment. We just take that from the same study as the champions. Okay, next column over, common cold. So we all know what the common cold is. When I set out to do this research, I was surprised to find that there are some interventions that apparently can decrease the duration of symptoms by some very, very, very small degree. So common cold, the scenario here is real effectiveness is basically 0. So imagine it's your grandmother and she's telling you on day 1 to take some, green tea, day 2, drink some echinacea, day 3, eat a bunch of vitamin C, interventions that we basically know are doing next to nothing. Placebo effect, common cold is also not very placebo responsive, so those numbers are really small, but natural course of improvement is very large. So our time frame here is say 5 days, and we're assuming that within 5 days the common cold is cleared up. So on any particular day, there's a 20% chance of the patient getting better without treatment. So that's where that 0.2 comes from. Antibiotics for infection. So here we're imagining there's a bacterial infection, and that infecting bacteria is extremely sensitive to this antibiotic. And so the drug is extremely effective. The infection is just not placebo responsive at all, and it doesn't really get better on its own. So imagine, like, for example, many common sexually transmitted diseases are like this. Like, they're not going to get better on its own, but they will improve within a week if you give antibiotics. Okay, so those are the clinical scenarios that we're modeling. So again, we plug those numbers into our model. We have 1,000 patient visits, the physician, and the physician is updating their credence in the strength, in the effectiveness of these drugs over the course of their career of 1,000 patients. So here's the kind of data that we get. This is a very messy graph. I'm going to be showing you a bunch of graphs, and I'm going to be moving quickly. So I'm sorry about the mess here. But the vertical axis is a representation of the physician's confidence in the effectiveness of the various drugs. The horizontal axis, is how effective the physician thinks the drug is. So that's a measure of effectiveness on the horizontal axis and a measure of confidence on the y-axis. And then the various colored lines represent the data on the 10 drugs. Now, in this scenario, this is benchmark 1, so there's no placebo effect, there's no natural course, and the 10 drugs have different effectiveness, and drug 10 was the most effective. So you can see, and it was effective at 0.9 strength. So you can see that blue line peaks right around 0.9, and that's exactly what we would want to see. So this is a happy scenario. This is a scenario in which the physician accurately infers the strength of the most effective drug. Now, there's some mess with the other drugs, but in a sense that doesn't really matter, because from the perspective of reliable inference, the physician has inferred the most effective drug. And this is a measure of how often the physician chooses the 10 drugs over the course of their career. And you can see that early on in their career, they just start choosing that most effective drug because they've learned it's effective. And so most of their prescriptions are that most effective drug. So again, happy result. Here we're modeling 20 physicians. So I'm going to show you an animation in which each row of this table represents the confidence of a physician, or the probability that the physician will prescribe a particular drug over time. And each column is representing each of those 10 drugs. So there's 10 drugs. In this scenario, all drugs are equally effective. So as the physician learns about the effectiveness of the drugs, we should expect that they're going to zoom in. They're going to start choosing the most effective drug. That's what we would hope, and that's what we see. So we see some flickering over time, but then as the careers advance, we see all of the physicians with a high probability choosing that most effective drug. That's the column on the far right of this graph. That red represents a high probability of choosing that drug. I'll just show you that one more time. So the careers start out a little bit kind of flickery. So they have a probability of choosing all the drugs in the early part of their career, but then they zoom in on the most effective drug. So that's a happy result. Okay, here's scenario 2. Again, this is kind of a benchmark scenario. All the drugs are equally effective at 0.5. That's that vertical dashed gray line. And again, with no placebo and no natural course of improvement, the physician's able to infer accurately the effectiveness of these drugs. So that's kind of a happy result. There's some over-favoring of prescriptions and some under-favoring. So again, this is like drug choice over time. But from the perspective of the patients, that's not a big deal because all the drugs are equally effective. Here's the same kind of animation that I showed you before. So the one thing that I want you to note here is that because all the drugs are equally effective, if you were God or you were God's physician, you would be choosing all of these drugs with an equal probability of 0.1. So God's physicians, this entire table, after enough experience, after seeing enough patients, would be white. The more blues you see and the more reds you see, the more we're seeing under-favoring and over-favoring. So here's what we see. We see a lot of flickering. There's some white, but there's lots of blues and lots of reds. And so even though the physicians are inferring the strengths of the drugs accurately, they still tend to be favoring particular drugs and under-favoring over drugs. So this kind of fallacy of favoring here. All right, antidepressants according to the champion's view. So here, the real effectiveness is at 0.6, and you can see that the confidence has shifted to the right. So the physicians are overconfident in the effectiveness of these drugs. I'm going to be moving quickly now through the rest of these graphs. There's some under-favoring of particular drugs and some over-favoring of others. And again, we see that pattern of under-favoring and over-favoring in this community of physicians. Okay, so that's antidepressants according to the champions. Here's according to the skeptics. So here, the drugs are stipulated to be completely ineffective. And we can see really radical overestimation of effectiveness. This is a big result. So what's doing the work here is, of course, placebo responsiveness. So we know as an empirical matter of fact that depression is very placebo responsive. And placebo is really driving this overestimation of effectiveness. Drug choice over time. And again, the community of physicians. This graph, there's not much to infer from this animation. Okay, common cold. So here again, the interventions are nearly ineffective, but we see this really radical overestimation of effectiveness. And what's doing the work here is natural course of disease. So in the antidepressants, according to the skeptics, what was causing the overestimation was placebo. Here it's natural course of disease. Okay, I'll skip over these. Here's antibiotics for infection. So again, all the drugs were equally effective and very effective. So the vertical dashed line there is at 0.9, representing the real effectiveness. And the physicians pretty much get this one right. So there's some under-favoring, there's some underestimating of effectiveness, there's a bit of overestimating, and there's some over-favoring. This is an interesting result. So here's drug choice over time. So again, all of these drugs are equally effective, and the physicians tend to favor one drug over the other. And we think what's happening here is just because the drugs are so effective, basically every time the physician prescribes a particular drug, the patient gets better. So they just end up settling on one drug, say drug 7 rather than drug 4. From the perspective of patients, that's not a big deal because all the drugs are equally effective and they're very effective. You might think, like, if you're the manufacturer of, say, drug 3 here, you might be unhappy with this pattern. But from the patient's perspective, this is sort of no problem. And again, you see this kind of real big flickers here on this kind of animation, the community of physicians under-favoring and over-favoring. All right, so just to summarize those results, we see in this model physicians favoring particular drugs, even when all the drugs are equally effective, and even when no drug is effective. And that overestimation of effectiveness is quite pronounced when diseases have some placebo responsiveness or some natural course of improvement. Those inferences are more reliable when there's no placebo or no natural course of improvement. I haven't showed you, so I've showed you all of these, all of our analysis is from the physician's perspective, the physician's inferences. We can also look at any particular patient, like how likely it is that they're going to get better if they just visit the doctor enough times. We've done this analysis. And basically, I mean, the result here, we don't need any fancy graphs or anything like that. The result is very striking that if you allow a patient to revisit a doctor if they don't get better. So suppose patient's Mary goes to the doctor, goes away with the drug, and she doesn't get better. So Mary goes back to the doctor, and the doctor changes her prescription from drug 2 to drug 4. If you allow Mary to visit, say, 3 or 4 times, at a certain point, she's guaranteed to get better, even if she's guaranteed to get better and infer that the drug was effective, even if it's completely ineffective. All right. There's two ways in which the model is idealized in the results that I just showed you. And so I'm going to describe those limitations, and then I'm going to show you ways in which we've kind of spruced up the model and give you just taste of more recent results. This is kind of fresh work that we've just done. Okay, so in the model, we're not allowing the physician to adjust their inferences based on their expectation of placebo or natural course of disease. Now, that's a really gross idealization, right? Imagine you're a physician and the patient comes to you with a common cold. Suppose you absurdly prescribed them some green tea and they go away and they come back a week later and their common cold is cured, you're not likely to infer that the green tea was the cause of your patient getting better. At least I hope you wouldn't, because you know that probably what's operating is the natural course of improvement. Our model is not allowing for that modulation of inferences, at least in the results that I just showed you. But also, our model is not taking into account well-known reasoning biases. So our model, basically, our physicians are perfect reasoners. They're perfect probabilistic reasoners, and they're perfect decision makers. And that's, of course, an extreme idealization, right? We know that people are shot through, patients are shot through with biases like confirmation bias, for example. So what we have been doing and have done is to de-idealize the model exactly along those dimensions. One thing that I want you to note is those two model limitations pull against each other. So if we allowed modulation of inferences based on knowledge of placebo and knowledge of natural course, that would, very likely, I mean, we can reason from the armchair here, we can predict that that's going to cause the overestimations of effectiveness to be less extreme. But on the other hand, if we add some plausible reasoning biases like confirmation bias, that's going to have the opposite effect. And that's what we see. So we spruce up the model, and what we get are results like this. Now, this is really fresh off the press. I've just gotten these graphs from the 2 PhD students that I'm working with just a few days ago. So what I'm showing you here is I've just taken one of those scenarios. This is in fact the antidepressants according to the Champion's view, but we've made a few adjustments to the parameters. And what we see is, so on the no bias, the figure on the left is exactly like the results that I just showed you. It's exactly the results from that model with the idealization of no biases. And so we see that overestimation. That's exactly like the overestimation that I just saw you. But now we've added on the figure on the right in the red, we've added what we're calling overestimation bias. This is like a confirmation bias. So the confirmation bias is basically you're a physician and you believe that this class of drugs is effective. So when you give a drug to a particular patient and they go off and they get better, and then they come back to your clinic, you kind of, in a sense, you can say you double count the patient getting better, or your confidence in that drug goes up more than it ought to if you didn't have this bias. And so you see the results more extremely exaggerate the overestimation of effectiveness. Okay, on the other hand, essentially this is a way in which we're modeling knowledge of placebo, this disconfirmation bias. So disconfirmation bias works in the opposite direction. It says, imagine, you're that patient, you're that physician, you're treating that patient who's got the common cold. You give them that green tea, they go away and they get better. You disconfirm that putative confirming evidence for the effectiveness of green tea. So you disconfirm it, you undercount it. And you undercount it precisely because you have good reasons to do so, because you think that what was actually doing the causing was the natural course of disease. So here we see exactly what we would expect to see. Now there's some quirky results here. You can ignore that solid line, but you see that without that bias, the overestimation of effectiveness is really large due to the natural course of disease. With that disconfirmation bias, it decreases the overestimation of effectiveness, exactly as we'd expect. So we see that those two biases, they pull each other in different directions. So we're essentially trying to, make our model more sophisticated to account for those biases. All right. Okay, so let me say a couple more things about this project. So many of you will have heard of this big movement, precision medicine or personalized medicine. So we think that we can model various aspects of precision medicine. So right now, the sort of disease categories that we're treating are all just one disease category, like depression. But we can carve up those disease categories into subtypes, just as precision medicine says they can for many diseases. And those subtypes can be differentially responsive to different drugs. So we can model two really interesting features here. We can model situations in which the diseases are actually divided up into subtypes that are differentially responsive to different drugs. Or we can model scenarios in which the disease is not carved up into subtypes, but the physicians think they are. Now, that I think is a very common scenario. So for example, here's a really common platitude that we hear in discourse about clinical medicine. A patient, again, let's call her Mary, she goes to her doctor, she's got depression, and the doctor prescribes SSRI number 2, say, Paxil. Mary goes away for 4 weeks or 6 weeks, doesn't get better, and comes back to the doctor. Here's a really common inference. The doctor doesn't lower their confidence in Paxil. The doctor infers that Mary is not a Paxil responder. Mary's not a responder to SSRI number 2, but maybe she's going to be a responder to SSRI number 4. So the doctor gives Mary SSRI number 4. She goes away, maybe she doesn't get better. And again, it's a common thing that physician will say, well, yeah, maybe I didn't get the dose right for you. Let's increase the dose. Or maybe you're just not an SSRI 4 responder. Maybe you're a number 7 responder. So we take that kind of pattern clinical practice to be quite common. And our model can represent that. Yeah, that's what I just said. And we want to add more reasoning biases to our model. Okay, so I said to you that the model in the early results that I showed you, the original model, represented physicians as like idealized reasoners. So there's no reasoning biases and they're perfect decision makers. Then we want to de-idealize the model. So we want to add various kinds of confirmation biases, various biases in decision making. But how strong should those biasing effects be? That's an empirical question. And we're not aware of very much careful work that directly speaks to those questions. So with colleagues in Denmark, we started a kind of experimental philosophy project in which we create a platform, like an online platform that has subjects put themselves in the perspective of the physician in our model. So you're facing a computer screen and virtually a patient comes to you and they're diagnosed with a particular disease and you've got to choose from a class of drugs. You give them that drug, they go away, they come back, they're either better or not. And we ask subjects to increase or decrease their estimation of the effectiveness of that drug using this kind of sliding scale. So suppose they started out this study, inferring, thinking that this class of drugs was, say, effective at 0.8. And then they see a patient, the patient doesn't get better. So the subject is allowed, if they decide they want to lower their confidence in the drug to some degree. And then they just cycle through a sequence of patients, and we just see how willing subjects are to move that slider around. Remember, if you're a strict EBM person, you should just always keep that slider on the same number, right? Because you're supposed to not believe that clinical experience can modulate your inferences in the effectiveness of the drugs. We haven't analyzed this data yet very carefully, but on a kind of visual look at the data, what we see is, and these are subjects who are medical students in a Danish medical school, what we see is really wide latitude in moving this representation of their estimate of effectiveness around on the basis of clinical experience. So that's the kind of experimental side of this project, and we're looking for ways to develop this approach as well, including what we'd really love to do is perform these kinds of surveys on physicians. Right now we've got medical students, but getting access to physicians is a bit harder. All right, that's pretty much what I just said. I'll end there, and I'd really like to hear what you guys think about this work. Thank you.
Okay, thank you, Jacob. This is fascinating, really. We open the floor for the audience to ask questions here or online. We have Tim Stockley first. Go on.
Hello, thank you. Fascinating stuff. If I understood correctly, your X5 survey with the medical students, I worry that moving a slider around is not a kind of study that would give you the ecological validity you're seeking for in this particular respect. And I think you have to study it more, in the lived reality of the clinic. This kind of study, this kind of experimental study, and I think also that an interesting idea would be to open yourself to the hypothesis that instead of fixed probabilities, most doctors and especially psychiatrists, and again, this is just a hypothesis, are operating according to a Bayesian model that continually readjusts probabilities. And I'm really curious to see the results of that model factoring in a Bayesian way of reasoning.
Yeah, thank you for that question. I completely agree with both points. So one worry that I have is the current user interface on that X5 study lends itself to, it really motivates moving the slider around. We've kind of gamified the pattern of inference. And my worry is that will just promote more extreme moves on that scale, even if it's not the case that their actual inference has changed that much. So we can imagine, this is a kind of thought experiment that I've been floating. Imagine instead of that scale, we had like physical jars of marbles, and each marble jar, the how full the jar with marbles represents your strength, your estimation of the strength of the drug, your estimation of the effectiveness of that drug. And so you might say, well, I read this meta-analysis, and so I'm going to fill marbles up to roughly, 0.6 on this jar. And then you see a patient, the patient doesn't get better. So how many marbles do you want to take out of the jar? So if it was like, the point is, if it was like physically hard to increase or decrease your representation of effectiveness, then you might get much less malleability, like much less variability in the data that represents estimates of effectiveness. So yeah, I share that first worry. And part of that comment too was about, aiming at ecological validity, where I would love to do this kind of experiment in which somehow we found a way to represent particular physicians or maybe trainees' estimates of the effectiveness of a drug over time based on clinical experience. That would be gold if such a study could be done. that's probably not a study for me to do, but I'd certainly like to talk to an experimentalist who wants to do that kind of work. And then the second part of your question was, remind me, it was
Factoring in Bayesian models.
Yeah, good, right. So at the moment, so in our model itself, our physicians are perfect Bayesian reasoners. And so when they make an inference about the effectiveness of the drug, they're perfect Bayesian. And then when they choose from the class of drugs, this is what's called a multi-armed bandit problem. This is just a technical problem that information technologists have to grapple with. And there's off-the-shelf analytic solutions to this choice problem that are fully Bayesian. So our results in that first chunk of first part of the talk were results from a perfect Bayesian. And the one question that we want to ask is, how much do these real subjects, like the students in Denmark, how closely do they track the ideal Bayesian? Yeah. Thanks.
Thank you.
Okay, thank you both. Next is Stefan.
Thanks. Right. So a very interesting lecture and your work in general. So I just have, since I'm in the clinic, I'll act as a kind of, not a position, but maybe I would like you to address, if possible, some points. And maybe I misunderstood some parts. So I hope that you will, clear that up. At one point, if I understood this correctly, you said that patient perspective also they can overestimate or underestimate whether the drug works. So the inference is then that the patient's experience cannot be trusted, whether the drug works or not. And since in psychiatry it's a bit different than rest of the medicine, especially since we are dealing with internal experiences of patients. So would that view constitute a kind of an epistemic injustice? So, and how would you go about addressing that? And also, so this is the first question. I can ask them like in succession, or if you want to take that, how are you like?
Maybe let me try to take a stab at that one first. It's a really important question. So I think there are strictly epistemic dimensions to this question, but then there's also, as you said, a question of epistemic justice or something like a kind of moral consideration as well. On the epistemic side, I mean, there's something. I mean, there's something deeply challenging about the question because, in some sense, the patient's experience has to be epistemic bedrock, right? That's like the grounds for any kind of inference we can possibly make. And particularly in psychiatry, as you said, because we don't have like, blood sugar measurements or heart rate measurements or anything like that. So the actual like phenomenological, at least what is conveyed by the patient as their phenomenological experience is epistemic bedrock. So I wouldn't want to deny that. What I would want to be cautious about is when inferences are made about the causes of changes to that phenomenological bedrock, both inferences on the part of the patient and on the part of the physician. Now, here too, I should express that thesis kind of cautiously. So I don't, as the main message of the talk is that there are circumstances under which those kinds of inferences are reliable. And maybe it will help to just briefly describe this kind of David Healy criticism. So Healy says, he gives this example. So he's a psychiatrist treating patients. He says, look, I can infer the effects of drugs. Here's an example. I give patients an SSRI, they lose their sexual functioning. I take them off their SSRI, they regain their sexual functioning. And so looks like it's a very persuasive argument that there's this effect of the drug that he can reliably infer. And I think that actually that kind of example fits really well with our results because when we're speaking about harmful side effects of a drug, even if the disease itself is placebo responsive, or even if the disease has a natural course, if we're speaking about a harmful side effect of the drug, the harmful side effect isn't part of the natural course, and the harmful side effect isn't part of the placebo. So it's plausible for me to think that with that kind of example, what we're seeing is an example that really fits the results of our model quite nicely. So I wouldn't want to doubt that like that kind of experience both is epistemic bedrock and the attribution of the cause to that experience is reliable. And then on the justice side, I think that here, I guess what I want to say is one can maintain a certain amount of skepticism about the causal attribution while also maintaining the like utmost importance of listening to the patient's conveyance of their phenomenological state and being sensitive to it and being sympathetic to it. So yeah, I guess is that satisfactory from your perspective?
Yeah, that's a great answer. So, and you actually answered in part another thing which I wanted to raise, and this is, like good clinical practice is based on evidence-based medicine in general, as far as I know. So, and it's also a point of doing your work in accordance with the law, right? So you kind of have that also this aspect that are you practicing by law, and this is by evidence-based medicine. As far as I know, in most Western countries, the situation is like that. But the data which you also provided, like that comes from meta-analysis, speaks about the effectiveness, and this is based on randomized controlled trials, which are based on psychometric properties. So, for example, the example of depression, it is that you measure whether the drug is effective by using a certain scale, and there are many critiques on the scales that we use, that they don't really measure. Actually, we don't even have a consensus of what depression is, as you said. So I guess my question is, since we are not dealing with something that is strictly speaking biological, but more importantly, a person who is embedded in a social context. So how is it possible, according to your work? I guess the key point that I wanted to ask you. So, if the drug worked, if the patient has that estimation, or the clinician, that he is getting better, and this is embedded in his social adaptation, or whatever you want to measure it by. So, is that enough of a reason, even if it's not the effective, even if the drug is not effective, so is that reason enough to doubt the medication's effectiveness? I guess taking into account the long-term risks and everything, this is the thing.
Good, thanks. Yeah. Okay, I think I followed the question, and there's a few important things to reflect on here. So, yeah, maybe I'll just start with an anecdote. So when I was in my first teaching job at University of Utah, I was working with some psychiatrists who they were based in a kind of intensive psychiatric ward. And so I would shadow the psychiatrists and see patients. And one of them, it was very interesting. He called himself a medical nihilist. So he had read my book, and he thought that everything I said about pharmaceuticals in psychiatry is right. And he would have these patients coming in who were on multiple, both recreational drugs and prescription drugs. And he viewed his job as getting them off as many drugs as possible in the short amount of time that his institution allowed him to see the patient, while keeping everyone safe. And of course, while satisfying the law and the constraints on his practice. So the general point is, one can be skeptical about the real effectiveness of a drug and grant that there are all sorts of constraints that anyways guide actual clinical practice. Some of those constraints can be institutional, some of them can be legal. And I think another class is also just our lack of really good empirical knowledge about what it's like to come off certain drugs. So we have this mountain of empirical evidence on what it's like to go on drugs. That's the whole point of randomized trials. But we have very few, like very carefully done experiments that test drug withdrawal. And so it would be naive for somebody to conclude that some class of drugs is effective and therefore decide all patients on this class of drugs should just come off them away, right? It would be naive both physically, medically, and also institutionally and legally. Yeah, so somehow what I would want to say is that we need a lot better evidence about how to manage the skeptical view in a like a legally, institutionally, and medically responsible way. Yeah.
Yeah,
Thanks.
that's great, thanks. And just a quick one, and I'll finish. So, and how would, drug discovery proceed, in your view, in the best possible way?
Yeah, thanks. So, I mean, one of the common criticisms of drug development now is this concern about so-called Me Too drugs. So, there's SSRIs are a big blockbuster. Some other company also wants an SSRI, so they chase this Me Too drug. Me Too, I also want an SSRI. That looks like it's pretty clearly a problem. So we're not exploring a broad enough space of possible kinds of interventions. And I think just also, I mean, your question is about drug discovery. I would want to generalize that to how should medical interventions, how should the pursuit of medical interventions be modulated based on the results of some of my critical work. And so with that more generalized question, I would say maybe we should be pursuing interventions that just aren't drugs at all. Maybe we should be pursuing other. So of course, there's this kind of platitude like, well, we've done this study, and if you read the epidemiologist John Ioannidis, he'll conclude that diet and exercise are just as effective as antidepressants. But actually, the evidence base for that is not that great. And it would be good to have a lot more evidence like that. And then, we had this question about being a Bayesian before, and I think that like a big part of my work and the kind of core argument in my book, Medical Nihilism, was sort of framed around this sort of Bayesian way of thinking. And one important consideration for that is we should be pursuing interventions for which we have relatively high prior probabilities of effectiveness. So, I mean, just to give an example, we have such a great track record with interventions like vaccines or antibiotics. It's really plausible that the next entry into the class of penicillins is going to be an effective tool in our arsenal. So that's an intervention for which I'd have a high prior probability. And so in general, I think that medicine, like drug discovery, should be informed by prior expectations of effectiveness more than it is now. So there's lots and lots of things that I'd want to say to your question. In fact, I mean, basically, my entire medical nihilism book was like a 12-chapter answer to your question. Yeah. Thank you for that.
Thank you.
Okay, thank you both. Do we have any more questions? Anybody else wants to contribute? People online? No?
Maybe I can just quickly say that Hamed and I are always open for different kinds of collaborations, and we're interested in developing the model in various ways, and we're interested in developing that empirical work in various ways. And so if anybody here has some ideas for development or collaboration, we're open to talking about it.
Thank you. Okay. So if we don't have any more questions or comments from anyone, let us thank Jacob Stegenga for his excellent, fascinating presentation today.
Thank you very much. Thanks for the interest. Thank you.
Thank you for being here, and thank you everyone for listening and commenting on the presentation, and hopefully I'll see you all on the next session of our seminar next month. Thank you all, and bye.
Thanks for hosting. Thanks for your questions. Bye-bye. Thank you.